Good afternoon to my fellow doctors and my seniors. Do you ever wonder when two patients come to your hospital with same HbA1c and same BMI but have different effects when we treat them with the same algorithm? Maybe we're treating the phenotype but we're not looking at the genotype. Within diabetes, we have only of two types, but only of type 1 and type 2. Majority of our clinic is filled up with the type 2 diabetes patients, but there is a small subset of patients who are having monogenic diabetes. This mistake often leads to increased insulin therapy instead of treating the genotype. When the treatment fails, we often think the problem is with the adherence or with the patient and not the biology. But sometimes treatment fails because we are targeting the wrong biological mechanism. So today we'll be discussing about biological heterogeneity in diabetes and review of supporting precision medicine approaches and how we can include these in our normal daily life clinic. So whenever we treat them with metformin, some patients will have a very good response to them, but others will have only have GI upsets. It's mainly due to SLC, W2A1 variants present. And whenever we treat patients with CYP2, C9 variants with sulfonylureases, there is an increased risk of hypoglycemia. And for all the patients, we don't need a full genomic model. We require only a few patients who need to go through monogenic diabetes testing. The framework I'm presenting today is it's a synthesis of narrative reviews from global registries and major literature. In a pan-India registry study of patients of 774, they were screened for monogenic diabetes, and the screening indicators were diabetes onset less than 30 years, parents with diabetes, and BMI less than 30, and there is no ketosis, and there is a preserved C peptide, and there are signs of glycosuria. Majorly in the study, they found that 15% were with monogenic diabetes, and majority of it was HNF1A or HNF4A MODY. It's mainly due to the major defect was due to beta cell dysfunction. The KATP channel is normal, so patients are highly sensitive to sulfonylureases, often needing very low doses instead of insulin. A clinical clue will be glycosuria at relatively mild glucose levels due to low renal threshold. The other subset was KCNJ11 or ABCCA8 neonatal forms, where there are KATP channel defects, and they are also responsive to sulfonylureases. So, genetic diagnosis changes therapy from insulin to oral agents in appropriate patients with improved quality of life. And the preconditions for changing from insulin would be antibodies negative and C peptide levels should be more than 200, and we should start them on low doses of sulfonylureases, and there should be monitoring blood glucose levels 4 times daily or CGM monitoring, and uh, and the safety rule would be if HbA1c raises more than 1%, we would restart the insulin therapy. and some of the biomarker drug selections could be done. In we can treat patients with SGLT2 inhibitors even when the sugar levels would be normal because of their cardiorenal protection. And we can treat some patients with GLP receptor agonist, but before treating anyone, giving patients GLP-1, it would be better to look at the C-peptide levels. If there are low C-peptide, giving GLP-1 receptor agonist would be not much of a use. And in the Indian context, Indian patients have a distinct phenotype where there is earlier onset and insulin resistance at even lower BMI. And there's a major limitation that the genomic data map is mostly of the European or Western data, and there's no much data available for the genomic panel of the South Asians. And in the future, maybe we can create a AI digital twin where we could integrate the genomics, biomarkers, and clinical data to support decisions. It would be just adjunct to the clinical judgment, not a replacement. So my conclusion would be not all patients with type 2 diabetes. There are some patients who might be having monogenic diabetes. So we should be screening them young atypical patients for MODI and use C-peptide to guide the incretin therapy. And we should prioritize organ protection and by prescribing SGLT2 inhibitors.
I think it should be insulin therapy and not incretin.